Good afternoon, everyone, and welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds series. Today, I have the pleasure and honor of introducing Dr. Juan Bustillo. Dr. Bustillo has been a member of the University of New Mexico Psychiatry faculty for 30 years. And in addition, he was a member of the DSM-5 Psychotic Disorders Workgroup. And we can see the title of his presentation on the slides, Psychiatric Diagnosis. Are we ready for a dimensional approach? So I will now turn over the Zoom podium to Dr. Bustillo and sit back and look forward to hearing what we're going to learn today. Thank you,
All
Dr.
right.
Bustillo.
Thank you very much, Dr. Varela. It's a pleasure. I hope to go over these slides and presentation over the next 45 minutes and leave a little bit of time for questions. These are my disclosures. And this is a brief outline of the presentation. I will start with the limitations of DSM-5 diagnosis. Then I'll go into the RDOC alternative, the high top alternative, and then the most recent proposal by Leucht et al. On cross-sectional psychopathological dimensions. And then we will go into the more general discussion on the purpose of diagnoses and how do dimensions fit or do not fit well into that. And that'll take us to a little bit of discussion on DSM-6, the little bit that we know is being considered for DSM-6. And then I'll go over conclusions and I should have time for questions. Okay, so a little bit of history. For some of you younger practitioners, let me remind you that before 1980, we did not have operationalized diagnostic criteria. It was only with DSM-3, and it was a big, big change in psychiatry. So the description of a syndrome in DSM-1 and 2 was just a clinical narrative. There were no specific criteria. With DSM-3, for example, in the case of mania, something that seems just very obvious now, we moved on to say, okay, there are 7 possible symptoms of mania that are well defined, and you need 3 out of 7 to be able to potentially qualify as having a manic episode. Seems pretty obvious. It wasn't like that. But also, you need a minimal duration of the presence of these 3 out of 7 symptoms. That was for mania a week. For depression, it was 2 weeks, 5 out of 9 symptoms. Again, the 1 or 2 weeks are arbitrary, but it was an important effort to be able to narrow down the universe of what we called a manic episode or a major depressive episode. Furthermore, because we started being specific and drawing a line, let's say a boundary, it was clear that some cases were left just outside the boundary. And some of those cases may be clinically significant. So in the case of bipolar disorder and mania, it was necessary to define hypomania. And I'm not going to go into that. Now, defining hypomania meant that there had to be another category within bipolar disorder, bipolar 2 disorder, for patients who only had hypomania and depression and never had mania. Furthermore, it was clear that not all patients with bipolar disorder had psychotic symptoms. That seems very obvious now, but before DSM-3, it was thought that because bipolar disorder was a very severe illness, it was assumed that psychosis was a standard feature of that. So a specifier of psychosis or not psychosis was added to bipolar 1. So you see how as soon as you start defining the symptoms and how many, you end up having to define more and more categories. Now, The immediate result of this approach with DSM-3 was the improved reliability. That we take that for granted. That seems pretty obvious. But before, there was minimal reliability. With this approach, it became clear, and the expectation was that a clinician in Europe would be very likely to agree on the diagnosis, the same diagnosis as someone in the United States with the same information across different languages, across different cultures. Very, very important step. Now, but reliability is not the only goal of DSM diagnosis. We also need validity. And there's different types of validity. The most obvious one is what we call face validity. And that one is just that it seems, the diagnosis seems to define what we mean. Yeah? It's not a formal type of validity. Then we have descriptive validity. And that means that the symptoms, in this case, the symptoms of mania, with the example we had before, those 7 symptoms tend to go together. Sometimes 4 of them go together for a particular patient. Sometimes all 7 of them, sometimes 3 of them, but they tend to naturally coalesce together. That's what's called descriptive validity of a syndrome. And it's not a given, and you can measure it. And for some syndromes in DSM, there's good descriptive validity, and for others, there's poor descriptive validity. Then we have what is called predictive validity. We hope that the syndrome will tell us something else that is going to happen in the future, that is going to happen or not happen in a patient. For example, a patient who has had mania is very likely to have a major depressive episode in the next several years. Yeah? A patient who has had mania is very likely, if they receive treatment and they don't get in trouble when they're manic and end up in jail and lose everything, is very likely to return to their premorbid level of functioning. That's what we mean by predictive validity. We learn something important about the prognosis. The last form of validity in psychiatric diagnosis is what's called construct validity. And this one is bringing in other variables different from the description of the syndrome itself and the course of the syndrome, other variables that are related to the presence of the syndrome and that inform us about the mechanism leading to the syndrome. So this is really the pathogenesis and the etiology of the syndrome. So that's the final form of validity that we want in medicine. Now, the other thing to keep in mind when we talk about what we're looking for in diagnosis like DSM diagnosis is, and this has been a limitation or a concern, is that diagnoses are comorbid. For example, patients that have the syndrome of schizophrenia, there's no question, we know this from many epidemiological studies, that 50% will suffer from a comorbid major depressive episode sometimes in their life. They have a 10% comorbidity chance of having obsessive compulsive disorder. They have a 40-something% chance of having substance use diagnosis. Okay? Now, it'd be fine if we have comorbidities, and we have comorbidities in the rest of medicine everywhere. For example, coronary artery disease is comorbid with kidney disease, with stroke, with hypertension. And that doesn't make us doubt the validity of coronary artery disease, probably because there is an underlying construct validity that joins these 4 comorbid conditions. Yeah, and that is atherosclerosis. The problem that we have with DSM-5 is that we have very limited construct validity. Atherosclerosis is part of the construct validity of coronary artery disease and hypertension and so forth. We have a problem there. Because of this, largely because of this, when DSM-5 was published, something remarkable happened. The director of NIMH at that time, Tom Insel, a research psychiatrist, very prominent research psychiatrist, in 2013 came out and said, there's a crisis of confidence in DSM-5. Remarkable statement. And his concern was, well, we do not have construct validity for any of these DSM-5 diagnoses, and they're going to be highly comorbid, and we need something better. And he went as far as for a few months saying, well, DSM-5 is going to be used by clinicians, but if you want a grant to be funded by NIMH, we are not going to fund grants that try to validate DSM-5 diagnosis because DSM-5 diagnoses are really worthless. He had to back away from that statement soon after that. But anyway, him and his group at NIMH put forward what was called the research domain criteria. And these are very interesting. I know we're spending a little bit of time on them. They are called the RDOC. And what the RDOC authors said is, if you look in the orange circle, they identify 7 domains, psychophysiological domains. These are domains that can be measured in humans and in animals. They are validated, and many of them have been related to different units of analysis in terms of neurobiology. So there's quite a bit known about circuits in animal brains and some in human brains. So the idea was, let's start with these psychophysiological processes, and we know a lot about them, and we have a good chance of linking them with the physiology, and let's measure these in humans with different psychiatric conditions, variety of psychiatric conditions, and then it is more likely that we're going to see connections between the phenomenology, the symptoms in those patients and these domains, and then link them to circuits. An interesting proposal. So let me go over the example of what has been done in terms of psychotic disorders with the RDOCs. Again, the idea is that you would start with a large group of patients with a variety of psychotic disorders that in the arrows you see they have elation, grandiosity, hallucinations, cognitive symptoms, negative symptoms. And the expectation would be is that those symptoms would be related to specific domains. All right, so let's go over this study, which is a very important study. It's called the BSNP study. It was the biggest study funded through RDOC to look at the pathophysiology of psychosis. Large study, about 700 patients, schizophrenia, bipolar, schizoaffective disorder, and very importantly, their relatives, their first-degree relatives, and healthy controls. And there's a lot of data in this study. I'm just going to focus on 2 aspects of the data. One is a measure of cognitive control. This is an RDOC domain. Okay, and I'm not going to go into the specifics of the cognitive task, but suffice to say that in this graph you see on the y-axis performance on the cognitive task, and 0 is sort of the standard performance in healthy controls. And along the x-axis you have different subgroups, and these subgroups, B1, B2, B3, segregated themselves. These are the psychotic patients, and they segregated in 3 different groups depending to their performance. B1, or biotype 1, as it was called by the authors, had the worst performance, B2 next, and B3 had normal performance. And none of these groups were more likely to have schizophrenia or bipolar or schizoaffective disorder. Very interesting. What was more interesting is that the relatives, although they all perform in the normal range, these relatives had no psychiatric illness, they had a stepwise deficit in performance that was parallel to their sick relatives. And that's what you see, relatives of B1, B2, and B3. Very interesting finding. Well, they use the information of performance in cognitive control, and then they looked at relationships with gray matter patterns. And what is shown in the left panel is the gray matter thinning compared to healthy controls for biotype 1 on the left, biotype 2 in the middle, and biotype 3. And more yellow and more colorful means greater cortical thinning. And what was remarkable is that biotype 1, the one that had the worst cognitive performance, had the thinner cortex, and then biotype 2 and biotype 3. But even more interesting, I think, is that the relatives of each of these biotypes also had a stepwise reduction in cortical thinning, similar to their ill relatives, suggesting that the relationship between a thinning of the cortex, impaired cognitive performance, was genetically caused, at least in part, in patients with psychotic disorder. All this is great. Now, so we go back to the expectation of the RDOC proposal for psychosis. We find this very nice relationship between cortical thinning and cognitive control deficits. We do not find that the bipolars or schizoaffectives or schizophrenics relate to the cognitive deficit, but the expectation was that the symptoms would relate to the cognitive deficits. That did not happen. So there was no relationship between symptom severity with any of the cognitive deficits. So because of that, the emphasis on RDOC, I think, at least in the study of psychosis, has really decreased. An alternative approach was developed a few years later. And completely different groups said, well, let's focus on the symptoms. RDOC did not focus on the symptoms. You saw. I mean, they started saying, no, let's look at these domains, psychophysiological domains. The high top approach said, let's focus on symptoms and let's start with data of tens of thousands of patients and their symptoms across a wide variety of symptoms across all patients. And let's feed the severity of those symptoms into a computer algorithm and see how these symptoms segregate. And what happened was very interesting. At one level, the symptoms segregated into 6 groups. This is what they call the spectra. And those are the names: detachment, disinhibited, externalizing, internalizing. Yeah. And you could see that some of those tended to be related to antisocial behavior, substance use, etc. However, none of these spectra have been able to be developed into empirical syndromes that are useful clinically. Now, that may happen down the road. Yeah. The idea is to come up with syndromes through allowing the symptoms themselves to segregate. Yeah, empirically. All right. I think that's enough for the alternatives, these previous alternatives to DSM-5. And that brings us to the paper by Leucht, Van Os, and Davis that was published a little bit over a year ago. These are very prominent research psychiatrists. Yeah, all of them are researchers in schizophrenia. 2 of them are clinical trialists. 1 is an epidemiologist. And they said, well, again, DSM diagnoses are not valid. They don't have construct validity. They are highly comorbid, which probably means that they are not sort of, they are not carving nature at its joints, so to speak. The RDOC and high top approaches, though interesting for research, they have no clinical utility, but the symptoms that patients present themselves with are real. Let's just focus on the symptoms and forget all this abstraction about diagnosis. And this is the heart of their proposal. So here you have like a a pie chart, and you have 28 symptoms that they selected. Yeah. And you have that for each symptom, the clinician is going to score anywhere between 0 and 4. 0 is not present. 1 is questionable. 2, 3, and 4 is different severity. And this is an example of a hypothetical patient. And you see that this patient, the area in gray, gives you a sense of how sick the patient is in terms of symptoms and which symptoms are causing the most distress. Now, for someone who is interested in schizophrenia like me and several of you, we may think, well, I mean, this is not bad. We have the 4 psychotic symptoms or positive symptoms are included, 2 negative symptoms, insight, which is important also, it's also included. So maybe it's not that bad. Now, for someone who is a geriatric psychiatrist, may think, well, if I'm dealing with patients with dementia, just an item on memory problems and disorientation, that may not be good enough. And for someone who is an addiction specialist, to expect that they will be able to capture the variability on the presentations of patients that have alcohol withdrawal, alcohol intoxication, substance use of different kinds of substance with just one item may be problematic. The point is that once you decide to go for symptoms, you're going to have to decide which symptoms to include and which symptoms to exclude. That's one problem. Now, but another problem that the authors recognize for this approach is, we may start with a cross-sectional description of the symptoms, and let's say we agree on a reasonable number of symptoms, but the illnesses that we deal with are for the most part chronic illnesses. So Leucht, Van Os, and Davis say, well, as part of the diagnostic assessment, we need to include previous mental health problems. And now you see the door is opened for saying, okay, so this patient, this putative patient had 15 years ago what we will call a depressive anxious syndrome, because we're not going to show another pie chart. And then 5 years later, this patient had a manic delusional syndrome. And then 3 years later, they had a hallucinatory paranoid formal thought disorder syndrome. And then you can start maybe scratching your head and thinking, well, if we're going to use these labels, what's the reliability and validity of these other syndromes? And you see now the limitations of a strict cross-sectional dimensional approach for psychiatric disorders. Yeah, because this approach attempts or makes it hard to deal with coarse information. And coarse information, the course of the illness is absolutely critical. In DSM-5, the course is acknowledged, and we say, for example, for schizophrenia, we need at least a month of psychosis. For mania, we need at least a week, etc., etc. So there's no way around that. The other big limitation of a dimensional approach is that it misses the exercise that is integral to medicine, which is differentiating primary versus secondary symptoms. Let me tell you what I mean. So we can measure blood pressure, a nice continuous sign. It's not a symptom, it's a sign, but we measure it with a low-tech device. It's very reliable, it's valid. It's a continuous measure with normality. But before we treat high blood pressure, even after we ascertain it 2 or 3 different days, we know it's a chronic problem. we have to rule out known causes of hypertension, what's called the secondary hypertension. And this is a long list. I'm not going to go over them. These are very rare causes of hypertension. They account for probably less than 5% of all cases of hypertension. But any physician will have to do that. And then after you've ruled those out, then you say the patient has primary hypertension. Even though hypertension is a continuous measure, you still need to go through this exercise of ruling out secondary causes of hypertension. For psychiatric syndromes or disorders, it's the same. Yeah. So we start with a patient like the case that was shown before in the pie chart, a person that has significant psychotic symptoms. You convince yourself that the psychotic symptoms are chronic enough. They're not just waxing and waning, but then you must rule out secondary causes of psychotic symptoms. There's some are very, very rare. Progressive supranuclear palsy, I've never seen. I've seen one case of temporal lobe epilepsy causing psychosis. But you clinicians in the audience know that there's plenty of patients that have drug-induced psychosis. And it matters deciding whether this is drug-induced psychosis or it's not. The treatment is different. And then you have conditions, very common psychiatric conditions, major depressive disorder, that can present with psychosis. Bipolar disorder, half of them, bipolar 1, presents with psychosis. And after you've gone through this exercise, you are left with primary psychosis, akin to primary hypertension. Now, that has been called schizophrenia for the last 100 years, and it could be called something else. But that's what the diagnostic label means. Now, after talking about the reliability of diagnostic categories, the validity of diagnostic categories, it's important to talk about the utility of a category. And a category, a diagnostic category, first of all, is important for communication between stakeholders. And these stakeholders are not just doctors and patients. You have researchers, hospitals, insurance providers, staff at courts of law, policymakers. And you can see how a category or a diagnostic label or dimensions have to be useful for these stakeholders. Most of you who see patients know that coming up with a diagnosis, for example, of schizophrenia and having to explain that to a patient for the first time or their relatives is difficult. Yeah, although there are operationally defined criteria for schizophrenia, you can say, well, it's a month of delusions, hallucinations, Explaining it is very, very hard, and especially when you have to tell the patient, no, there's no test, like in other conditions in medicine. We don't have a test, okay? And it's a condition that is highly stigmatized. The word is highly stigmatized. Now, think about explaining this to the patient and the family. Is it going to be more useful? Utility depends on two characteristics: the quantity and quality of the information that we have for that diagnosis, and the implications in terms of prognosis and treatment that that diagnosis carries. Let's examine those in two overlapping psychiatric diagnoses. So here we have schizophrenia and bipolar 1, and we're looking at validators. Yeah, we're looking at validators. So there's been thousands of studies in schizophrenia and bipolar disorder using high-resolution MRI. Clearly, there's diffuse, mild cortical thinning in schizophrenia and a little even milder in bipolar disorder, but they're present. Still, we cannot use an MRI to help us with the differential diagnosis of schizophrenia or bipolar disorder. We cannot even use it to help us with the differential diagnosis between schizophrenia and healthy controls. In terms of validating with pathology, what's most striking is what we don't see. We do not see widespread loss of neurons with gliosis. Gliosis means scarring in the brain. We don't see that, even though the cortex is thinner in bipolar disorder and schizophrenia. Now, in the dementias, we do see gliosis. So that's striking. In terms of cognition, there is a mild global cognitive deficit in schizophrenia, and even milder cognitive deficit in bipolar. And in terms of progression, the predictive validity in schizophrenia, progression of the disease tends to be gradual. In bipolar disorder, tends to be episodic. Now, there's a lot of overlap, no question. Now, so that in terms of validators for these two disorders. What do we know in terms of clinical implications? Let me just mention these four. So the first line of treatment for schizophrenia is an antipsychotic. The first line of treatment for maintenance in bipolar disorder is lithium or valproate. Lithium and valproate absolutely do not work for schizophrenia. Have no place. Yeah. We sometimes, as second-line treatments, end up using antipsychotics for bipolar disorders. Yeah. However, the risks of developing a very serious neurological condition, which is called tardive dyskinesia, are higher in bipolar disorder than in schizophrenia for reasons what we don't understand. But these are important clinical implications. And finally, like I said before, half of the patients with schizophrenia will have an episode of major depression, and they should be treated with antidepressant medication. More than 3/4 of patients with bipolar disorder will have a major depressive episode. And these major depressive episodes, even though they look exactly like the depressive episodes in patients with schizophrenia, they do not respond to antidepressant medication. Striking difference. Actually, there's been a big push, and it has been found over the last decade that a few antipsychotic medications can work for bipolar depression. Very important clinical implications that are different between both diagnoses. So now let's talk about, well, why haven't we validated any of our psychiatric diagnoses? One possibility is that these diagnoses are just inventions. Yeah, like Leucht says, or like Tom Insel thought 15 years ago. Or it is possible that although these diagnoses are not perfect, that the tools that we're still using are too coarse. We're used to thinking and seeing in the media that neuroimaging and genetics are just so incredibly powerful. And they are, but it doesn't mean that they have enough resolution to address subtle differences in some conditions. And these are some of the tools that we've used to try to validate these conditions. So let's look for, as a test, how do some of these tools work in two specific diagnoses that are part of the major neurocognitive impairment category. So we have Alzheimer's disease and vascular dementia. Yeah, they've been described for over 100 years. Well, there's been thousands of studies looking at high-resolution MRI in Alzheimer's and vascular dementia. Yeah? In terms of the cortex, they do find thinning of the cortex, just like we find thinning of the cortex in schizophrenia and in bipolar disorder. It's not enough to help us differentiate Alzheimer's from normal aging or Alzheimer's from vascular dementia. The best tools we have right now is that with MRI, where for some patients with vascular dementia, we see more white matter hyperintensities. Yeah, and that's helpful. And that's reassuring because vascular dementia is characterized by microinfarcts. And those microinfarcts, if they are in the white matter, they can often be detected with MRI. For Alzheimer's disease, the best tool that is available right now is PET with amyloid or tau ligands, radioligands. Yeah. And this is interesting and it's valuable because it's measuring in vivo some of the things that we know are in Alzheimer's disease in post-mortem examinations, amyloid plaques and tau tangles. However, the resolution of these PETs is not enough to be able to become the standard of care to diagnose most or every patient with Alzheimer's disease. Yeah. And there's a lot of overlap. There's lots of patients with vascular dementia that have increased deposits of tau and amyloid, and a lot of patients with Alzheimer's disease that have high white matter hyperintensities. In terms of clinical characteristics, we have some indications that can be helpful. They're not definitive. Yeah. In Alzheimer's disease, the early symptoms are more focused on memory, and in vascular dementia, often they are focused on executive function. And the progression is gradual in Alzheimer's, and it can be more stepwise in major neurocognitive impairment. The point is, even for these well-defined neurological disorders, the best neuroimaging techniques that we have not been able to find a clear place in standard clinical practice. And furthermore, there's a big percentage of patients that have mixed dementia. So although this is most likely a continuous process, there's no just pure Alzheimer's and pure vascular, that is a continuous process. It's still helpful in neurology and psychiatry to think of the categories of Alzheimer's and vascular dementia. Okay, in the few minutes that I have, let me just show you two studies that I think support the idea that there are good construct validators for schizophrenia and bipolar disorder. One study is remarkable. It was just published last year in JAMA Psychiatry. The lead author is Ken Kindler, and he did it with a group in Sweden. So this is a very interesting study. It's an epidemiological study. It's a very sophisticated epidemiological study. They looked at all the psychiatric records of all people in Sweden for 50 years. Yeah. And they followed each of those persons for at least 20 years. They follow the records. In Sweden, there's socialized medicine. It's a small country. Their psychiatric records are excellent. Everybody, has a right to go to get care wherever they are and whenever they need to. And those records are maintained. So in this study, the authors found 17,000 cases of people with schizophrenia, 58,000 cases of people with bipolar disorder. This included bipolar 1 and bipolar 2, and about 7,000 cases with schizoaffective disorder, and about 700,000 cases, it's not listed here, with major depression. But most importantly, they looked for the linkage between any person that had a diagnosis and their first, second, third, fourth, and fifth degree relatives. So what was the likelihood that someone having a diagnosis will also have relatives with those diagnoses? And they went all the way down to the fifth degree relative, which I'm not aware that had been done in psychiatric disorder. Furthermore, they controlled for cohabitation. So whether the two relatives grew up together. This is very important because it allows you to make inferences if there is a familial association for a disorder, whether it is environmental or whether it is genetic. Okay, so with that, they generated, and I'm not going to go into the details, I don't understand them, but a number that goes from 0 to 1 for what they call the schizophrenia genetic risk, and similarly, a bipolar disorder genetic risk from 0 to 1. So that's what you see in the y-axis, the schizophrenia genetic risk, in the x-axis, the bipolar genetic risk. And then they looked at the groups. And here in blue, you have the schizophrenia blue, 17,000 subjects, and you see the scores for schizophrenia genetic risk. Great. It's almost 0.8, very high. And interestingly, it still is 0.2 for the bipolar genetic risk. So there is a shared genetic risk between both of these disorders. These are not Mendelianly transmitted illnesses. That is clear. They're very complex genetic disorders with thousands and thousands probably of variants, genetic variants. But this validates that schizophrenia, the diagnosis of schizophrenia, from the genetic point of view, there is construct validity for that. Let's look at bipolar disorder here in orange. On the opposite side, you see a 60.62 genetic risk for the bipolar disorder, and the bipolar disorder only has like a 0.18 schizophrenia genetic risk. Some overlap, but not a lot. And where does schizoaffective disorder fall? Right in the middle. There's a genetic risk of almost 0.7 in terms of schizophrenia for schizoaffective disorder and about 0.5 for bipolar. They also looked at other rare psychotic disorders, which is very interesting. And those are these three in green. The red one is delusional disorder, the blue is psychosis not elsewhere classified, and the green is acute psychotic episode, or what we call brief reactive psychosis. And you see that they have a genetic association with schizophrenia and with bipolar, but clearly less than the major three syndromes. And where is major depression? It's down here in red. So minimal risk, genetic risk for schizophrenia, people with major depression, and a significant but low risk of bipolar genetic risk. So I think is a very beautiful example of validation of these three syndromes with a relatively low tech methodology, but a beautiful data set. All right, so let me just show you this other one because it's a very sophisticated methodology. This is actually a genome-wide association study from the Psychiatric Genetic Consortium. This is the largest comparison, head-to-head comparison of bipolar versus schizophrenia versus healthy controls. The results for just healthy controls versus the psychiatric patients are clear. There's 114 loci that are different between the patients and the controls. I'm not going to show you that. I'm just going to show you the comparison, the head-to-head comparison between the bipolars and the schizophrenia. And out of millions of genetic loci, only 4 met statistical significance after controlling for multiple comparisons. Of course, there's more genetic loci examined, there's millions of them, than patients. So the multiple comparison standard is very, very strict. Still, 4 loci were found to be significantly different between schizophrenia and bipolar. This supports that there's validity in terms of strict genetic measurement between schizophrenia and bipolar disorder. However, it's interesting that the lower tech epidemiological study was able, with relatively similar samples, to detect a more robust effect than the genome-wide association study. That, to me, it says how much we don't understand about the genome yet. Okay, and that takes me to one of my last slides, and it is DSM-6. And this is from a recent paper in 2026 from the Structure and Dimension Subcommittee. So there's already a dimension subcommittee. And that's because this is what they are thinking of, how they're thinking of structuring the diagnosis across DSM 6. This is by no means definitive. So they're going to look at, in yellow, contextual factors. They even have biological markers. We'll see whether that comes to fruition. And they have diagnosis, good, simple diagnosis. And you see here, for an example, they'll have a specific diagnosis with a specifier, for example, PTSD with dissociative symptoms, but good old cross-cutting clinical dimensions are still put forward like something to pursue. We'll see how far they go. And this reminds me when we were in the DSM-5 psychosis committee, there was pressure to include dimensions. Yeah, the idea was, well, what I've told you, the diagnoses are not fully valid. There's no biological correlates that have been found to give us construct validity. Dimensions are more closer to the actual reality, the symptoms. So we ended up including these 8 dimensions with the recommendation that every clinician who sees a psychotic patient will rate the patients in these dimensions. Now, that was 15 years ago. And I don't know how many of you have used these dimensions when you have seen patients with psychosis. But this is what we gave up. We gave up a measure of heterogeneity, of symptom heterogeneity, which were the subtypes of schizophrenia. And these subtypes had been around for 100 years. Yeah. And they were not, the validity was minimal. Yeah. But some people found them helpful. So I hope I've persuaded you that, we're going to need categories. Yeah. And it's not either choosing dimensions or categories. We can have both, some of both. I think it's much more an issue of whether your predisposition as a clinician is to lump diagnosis or to split diagnosis. Here we have the example of schizophrenia and bipolar disorder. Right now, they're split. We have schizophrenia in one chapter, bipolar disorder in another chapter. Yeah. And within schizophrenia, we have subgroups. Yeah, or we had other diagnostic qualities. One of the diagnostic categories. One is schizoaffective disorder, but we know schizoaffective disorder is part of schizophrenia. Yeah, and we have bipolar disorder with also categories within bipolar disorder. So someone could decide, and actually this was proposed several times for a while in DSM-5 to lump these two and to have just a psychosis dimension, a psychosis dimension, and just that's the category that we use, and then we just measure symptoms, different kinds of symptoms. Now, the problem with that approach is, what do you do with the 3/4 of bipolar patients who will never have psychosis? Yeah. Anyway, so in conclusions, in medicine, we will need categories. In the absence of diagnostic tests, we want to have reliable clinical measures in psychiatry. We measure with continuous measures sometimes, for example, blood pressure, or nominal measures. The patient has hypertension or not, has schizophrenia or not, or ordinal measures with symptom ratings. Again, it's not so much about dimensions versus categories. We need categories. It's more about lumping versus splitting. I would submit that the operationalized criteria with DSM-3 to 5 have served us well for patient care, communication of needs, and research. However, they clearly do not carve nature at its joints. It may be because the tools that we use, as sexy and high-tech as they are, may still be too blunt for complex brain structures. Remember the high-resolution MRI at 3 Tesla. We only get 1 cubic millimeter. And the cortex, the human cortex, is 2 to 3 cubic millimeters. And if there are problems in the cortex, in these illnesses, they're going to be at the level of layers within the cortex. So it's not surprising that a lot of high resolution MRI studies haven't been able to carve the disorders at their joints. Many categories are just labels. Of the 500 categories in DSM-5, many are just labels. Hopefully, they're helpful labels. However, there are some categories that are well-characterized syndromes, which have very important implications. And I leave you guys with this picture, and that's the end. And now I can go back if we have time for any questions.
I did have one thought, Dr. Bustillo. First of all, I really enjoyed this talk, and I appreciate the sort of historical insight that you bring into the DSM. This idea of like symptoms, um, diagnosing based off of symptoms, or a constellation of symptoms, versus using some more like diagnostic tests to aid in our diagnoses is really interesting. And specifically in psychosis, I'm thinking about schizophrenia or psychosis. Here you sort of highlighted genetic causes, but we know that psychosis can also sort of linger after extended substance use, and sort of that would sort of argue maybe more for labeling based off of this constellation of symptoms, as like genetic tests would sort of fail in this way. But I'm curious what you think about that, and how you think that this type of psychosis caused by substance use that we see a lot here in New Mexico and the U.S. I'm curious how you think this kind of fits into these labeling schemes.
So that's a very interesting point, and clearly we know that substances are risk factors for psychosis. Now, and it's interesting because not all substances are the same. So something that's been very interesting over the last 20 years is that THC is a particularly toxic risk factor. And you can always think, well, you can always remember, well, I had this patient who used very high potency THC and became psychotic, and he remained psychotic. Yeah. And that sort of sticks in your mind, and you say, well, this is very, very important. However, the epidemiological data, and I'm thinking of a Danish study, it is very clear that when you look at people that show up in the emergency room, yeah, with substance-induced psychosis, specifically THC-induced psychosis. You remember, there's millions of people smoking weed all the time, and they get a super high, and they never end up in the emergency room. So there's a very selected population that end up in the emergency room, and they end up getting a diagnosis of substance-induced psychosis. Okay? A third of those patients within a year, when they're followed in the Danish epidemiological cohort, who never had psychosis before, will transition to either bipolar disorder or schizophrenia. So it's not so much, it seems, that, the drugs are incredibly toxic and people just get psychotic. Some people just get psychotic. It seems that people that have the vulnerability to develop psychotic disorders some of them are particularly vulnerable to being exposed repeatedly with high concentrations of THC, and that just ends up unmasking the psychotic disorder. So that's what these epidemiological studies suggest. Let's leave time for someone else who may have another question. We only have 5 minutes. Any other questions or comments?
Thank you, Dr. Bustillo. Maybe quick question of any
Sure.
other books, podcasts, articles, or people to go get coffee with to talk about the background and context of the evolution of DSM diagnostic criteria, some of the, things that went into it or the
So
content.
you're interested in the history. Look for me in the clinic, and we'll talk about that.
Cool.
Anybody else? Any comments?
Go.
Jennifer, yes?
I'll go. Thank you, Dr. Bustillo, for your lecture. So, would you say, with this concept of carving nature at the joints,
Yes.
I have kind of like a ontological question. Do the joints actually exist? And it seems to me that, historically, everybody has seen kind of different joints.
Yes.
Kraepelin was seeing some joints, and Bleuler other joints, and Schneider the joints that
Yes.
the joints that I like. And so, how much it seems that we have moved to biological psychiatry, and the move is towards biology. But do you think that's where the joint is?
Yeah, so that's an excellent question. Where is the joint, and is there a joint? So, we know that in several models of neurological disorder, there's clearly a joint. So if you start just looking at intellectual disability, IQ, you see there's a continuous there's a bell curve in terms of people with high IQ and low IQ and very low IQ and intellectual disability, and then some syndromes within intellectual disability. And many of those syndromes, there's no joints, but there's somewhat that clearly there's a joint. Yeah, if you have 3 chromosomes, 21 chromosomes, then you have Down syndrome. And it's not just that the IQ is lower and there's variability in the IQ, but there's all sorts of gross abnormalities in all sorts of systems in the body. So there can be joints and there are joints, but we haven't found them yet. We haven't found them probably because we know so little about the brain. Yeah, we really know so little about the brain. And we know so little about the genome. That's the other important thing. We say we've mapped the genome. All these illnesses are hereditary. So schizophrenia is, 70 to 80% hereditary. Autism is 90% hereditary. But the genome, 95% of the genome, we don't know what it does. Yeah. There's only 25,000 genes, and there's all this other genetic material that we don't know what it does. Yeah. So the complexity of the problem is such that it doesn't surprise me that we haven't been able to validate these disorders yet. It doesn't mean that they're not valid. It doesn't mean that these categories are the best categories, but you shouldn't throw the baby with the wash water. There are many of these categories that have proven themselves to be helpful, and they are helpful. Any other questions? I think we're out of time. Dr. Varela, is that right?
Yes, we are out of time. Thank you, Dr. Bustillo. I'm sure I'm expressing the sentiment of the entire department and thanking you for your time and expertise and sharing it with us. I believe we've all learned a lot today and how to think about diagnosis beyond what's just on the surface. So thank you.
All right. Thank you
Thank you,
very
Juan.
much.
Excellent
Bye.
presentation.